Nematodes are also known as the nemathelminthids, and they are found and they ultimately infested humans from the different areas. For example, from the soil, Ascaris lumbicoides can be transmitted like this. Platyhelminthids can be divided into trematodes and cystodes. Trematodes are also known as the flukes. Example is the blood flukes like schistosomiasis, liver flukes that infest the liver. Example is Clonorchis sinensis. Lung flukes is paragonimiasis. Intestinal flukes is the fasciola hepatica, fasciolosis. Within the cystodes, it can be beef tapeworm. It is caused by the Tinea saginata. Pork tapeworm, it is caused by the Tinea solium. Fish tapeworm caused by the Diphyllobothrium latum, and dwarf tapeworm caused by the Hymenelope nana. So you will read about these names. These are important. Of this tapeworm infestation, flukes infestation are important. So you can see these are the pictures of like roundworm, hookworm, filariasis, pinworm, male and female, etc. So these are picture under microscope. This is tapeworm, whipworm, onchocerciasis, and fasciola hepatica. So what are the common helminths? We can commonly call this as roundworm, hookworm, threadworm, etc. Roundworm is basically Ascaris lumbicoides. Hookworm is Ankylostoma duodenale and Necator americanus. Threadworm is Enterobius vermicularis and Strongyloides stercularis. Whipworm, Trichuris trichura and Trichinella spiralis. Filaria is basically caused by Boucheria bancrofti and Brugia malloy. Tapeworms are caused by different types of the Tinea species, Tinea solium, saginata, and Hymenelope nana. Hydatid disease. It is caused by Echinococcus granularis and Echinococcus multilocularis. Guinea worm, this is now eradicated from the world. It was caused by the Dracunculus medinensis. So now coming to the anti-helminthic drugs. So those drugs that are active against these helminths, this may be again classified into either vermicide or vermifuge. Vermicides means drugs that kills the worms, and vermifuge means that expels the intestinal infestational helminths. Mostly these helminths are infested with the host like the humans, and they are expelled out from different excretory system. This can be excreted by peristaltic movement of the intestine or cathartic and purgative action. So we can do some catharsis or purgation by means of different types of the drugs. Ideal anti-helminthics should be orally effective because it is easy to give and easy to give for mass eradication of the helminthic infection. You know the helminthic infection quite common in schools or in teenage age groups or in hostels, etc., where we need some mass treatment. So for this we need some oral medication. Effective in single dose because again it is easier to give, inexpensive, and wide safety of margin with highest toxicity to worms and lesser toxicity to host. So it should be safe to the humans. So these are the available drugs. Of this, the most important is the bench imidazoles group. Within the bench imidazoles groups, the three most important is the mebendazole, albendazole, and thiabendazole. Apart from this, there are other anti-helminthic drugs. Examples are pyrantyl pamoate, piperazine, levamisole and tetramizole, diethyl carbamazine citrate, ivermectin, niclosamide, praziquantel, and metronidazole. So these are the different names of the drugs that are active against the helminths. So first coming to the mebendazole. Mebendazole is the prototype anti-helminthic drug. It belongs to the nitroimidazole group. You can see this is the structure. This is slow in action, takes 2 to 3 days to develop. Site of action is microtubular protein beta tubulin, and it inhibits the polymerization of the protein. Basically all this inhibits the protein synthesis machinery in the worms. Intracellular microtubules are gradually lost. A range of other biochemical changes are also happening within the worms. For example, inhibition of the mitochondrial fumarate reductase. This mitochondrial fumarate reductase is important for respiratory chain in case of the worms. Without this, the worms cannot synthesize the ATP that is needed for its survival. Reduce glucose transport. Again, glucose is needed for its metabolism. Blocks glucose uptake in the parasite and depletion of the glycogen stored within the worm, and uncoupling of the oxidative phosphorylation. So if it is uncoupled, again the respiratory chain and ATP synthesis will be uncoupled, then there will be no protein synthesis. So it is of minimally absorbed, 75 to 90% is passed unabsorbed in the feces, excreted mainly in the urine. Adverse effect is very mild, some allergic reaction can happen. So it has 100% cure rates for roundworm, hookworm, enterobius and trichuris. 75% effective for tapeworms, but it is not effective against the Hymenolopus nana. Hydatid cyst. For hydatid cyst, it needs a prolonged treatment. Hatching of the nematode egg and larva is inhibited and Ascaris eggs are killed. It is available basically as a chewable tablet, 100 milligram. Common indications for this roundworm, hookworm, etc. 100 milligram twice daily for 3 days. So it needs 3 days and multiple dosing. Enterobius again 100 milligram single dose and repeat after 2 to 3 weeks. Similarly, 200 milligram or 400 milligram twice daily, and again it is to be given for 3 to 4 days. So now the congener comes, and it is now most commonly used. This is the albendazole because it can be used in most of the cases the single dose, and it is also available as a intravenous dosage form if there is infestation within the viscera or within the brain. So this is the congener of the mebendazole, comparable efficacy with mebendazole for roundworm, hookworm and enterobius. But it is less effective against trichuris, more effective against strongyloides tuberculosis. Trichinella effectiveness is same, more effective in tapeworm and hydatid larva and ova of Ascaris and hookworm. It has very weak microfilarial action and cutaneous larva migrans. It is moderate and inconsistent oral absorption. Fat meal enhances the absorption. That's why albendazole should be taken with food or after food, and the food should contain some amount of the fat. Fraction is converted to sulfoxide metabolite, which is the active form of the metabolite, and it penetrates brain with T half of the 8 to 9 hours. So this is the basis of tissue anti-helminthic action. So mebendazole usually do not have tissue action. Mainly it acts within the intestinal system and it excretes the parasite. But albendazole may act within the viscera if there is infestation of the worm occurs within the viscera. For example, it can penetrate the brain. So if there is some infestation within the brain, some ova or some larva, that can be treated with albendazole. For intestinal worm given in empty stomach, and for tissue actions with fatty males. So those worms that mainly infested only within the intestine, it should be given in empty stomach. But in most of the cases, we are using albendazole when we want to eradicate both in the intestinal as well as if some forms of the ova is present within some viscera, and that is the main form of the transmission. So we have to give this mostly after food, after some fatty food. Dosage, usually it is available as 400 milligram tablet and syrup. In most of the cases, when there is pinworm infestation, that is quite common in school-aged children, you know, a single dose is usually given, and it should be repeated after 2 weeks because the ova can mature after 2 weeks, the ova of this pinworm or roundworm. So single dose 400 milligram. Tapeworm, again it is needed for some longer period, 3 days. Cutaneous larva migrans, again 400 milligram for 3 days. You can see this is the neurocystosarcosis. This is the cystosarcosis. This larva and ova are present within the brain. It is transmitted within the brain, and that leads to seizure, and death can also happen. This is known as the neurocystosarcosis. Here the intravenous dose of the albendazole is given, 400 milligram twice daily for 1 to 2 weeks usually given. Again for hydatid disease. So hydatid cyst can develop again within the liver, within the lung. It can develop within the brain also. Here it is given for 4 weeks. You can see 400 milligram breathing for 4 weeks. Treatment of choice before and after some surgery. In most of the cases, hydatid cyst is removed by surgery. But during surgery, if the cyst is spilled over, that can lead to widespread infection. That's why before surgery of the hydatid cyst, we have to give some anti-helminthic drug, most commonly the albendazole, to kill the different types of the worms, and then we have to do the surgery. For the filariasis with DEC, that is the diethyl carbamazine or ivermectin in lymphatic filariasis, and used in mass programs, what I am talking. So most of the cases it is included within different types of the programs for eradication of worms, and it is contraindicated in pregnancy. This is to remember, it should not be given in pregnancy. Thiabendazole is another benzamide. Basically, this was the first invented. Its clinical value has declined because of different types of the toxicity. Triclapendazole. It is specifically used for the treatment of the liver flukes. You have already seen that the flukes are the trematodes. So these are the trematode infection, most commonly that infect the liver, especially fasciolasis. Fasciolasis is caused by the fasciola hepatica and paragonimiasis. So this affects the liver. We can treat this by triclapendazole. Single oral dose of 10 mg per kg is effective. No significant side effect. Previously, another agent, bitonol, is used for fasciola hepatica infection, but it is less active against Necator strongyloides and trichodes. Mechanism of action, they activate the nicotinic cholinergic receptors and causes persistent depolarization. So when the persistent depolarization of the worms occurs, that leads to contracture and spastic paralysis, and that ultimately leads to expel of the worms. So the worms ultimately, by means of the hook-like action, they infested the intestine, and these are expelled by spastic paralysis and contracture of these worms. Piperazine causes flaccid paralysis, and which have antagonizing action. This is a separate drug. So adverse drug reaction more commonly very less, and these are not so important. So remember, pyrantel palmoid basically acts by activating of the nicotinic cholinergic receptors. Piperazine is just opposite of this pyrantel palmoid. This pyrantel palmoid causes spastic paralysis, and piperazine causes flaccid paralysis. Flaccid paralysis, hyperpolarization of the ascaris muscles, decreased responsiveness, purgation often required, and does not excite. So again, it is highly active against the ascaris and enterobius, but second choice drug. The first choice drug is of course the different types of the bendazoles, albendazole. Then the piperazine can be used. It is less or not active against hookworm. That is, it is active only against the roundworm, that is the Ascaris lumbricoides and Enterobius vermicularis. Libamizole and tetramizole, they are effective against any nematodes but restricted to Ascariasis and Ankylostomiasis. Ankylostoma duodenale is another agent. Mechanism, they again causes tonic paralysis of worms and expulsion of the live worms by stimulating ganglia. These ganglia are present within the worms. They stimulate this, that causes a tonic paralysis, and the worms are excreted. Inhibition of the fumarate reduction, of course, occurs. In many of the cases, they decouples the oxidative cycle with the respiratory chain. Dose the similar, usually the single dose is given. The name is lebamizole and tetramizole. Diethyl carbamazine citrate. Again, this is important after the albendazole. Albendazole is the most important drug. Next important drug is the diethyl carbamazine citrate, because it is used specifically for the filariasis, loesis, and tropical eosinophilia. It has been seen that in some of the cases, the eosinophil count continues to rise and becomes rise for months or years, and that may happen due to some filaria larva. This is known as the tropical eosinophilia. This is a synthetic piperazine derivative, rapidly absorbed from the gut, half-life of 2 to 3 hours, which increases in alkaline urine, excreted in urine unchanged, and dose is reduced in urinary alkalosis and renal impairment. Mechanism of action, they mainly alters the microfilarial membrane. Microfilaria is the agent that causes the filariasis. They alter the membrane, and ultimately that is readily phagocytosed by the tissue monocytes. Since it is a piperazine derivative, they also causes the hyperpolarization and muscular weakness of the worms, and again they are expelled. So diethyl carbamazine citrate, they are used in 50 mg, 100 mg tablet, and suspension is also available. For the filariasis, the dose is 2 mg per kg thrice daily for 7 days. Usually the dose, it is like this, it is given. Intermittent microfilarimia is a problem. So 100 mg per kg for 3 weeks is given. That is, prolonged treatment is given, because some of the patients have repeatedly, they are infested with the microfilaria. So prolonged treatment with different schedules has been found to achieve radical care in most patients. Elephantiasis is not affected. So when you will read the filariasis, you will see that there may be blockage of the lymph nodes and lymphatics. That may lead to swelling, very large swelling of the legs. This is known as the elephantiasis. This diethyl carbamazine citrate kills the filarias, but they directly do not have any effect on the elephantiasis. That is, this elephantiasis, if it has been developed due to blockage of the lymphatics, ultimately that cannot be treated by diethyl carbamazine citrate. Most of the cases, it ultimately remains for the lifelong. But if the filaria are killed, that will not progress. Tropical eosinophilia, for it is 2 to 4 milligram per kg thrice daily for 2 to 3 weeks is given. So long duration treatment is often needed with diethyl carbamazine citrate for filariasis. Adverse effects are again very less, some nausea, vomiting, etc. etc. We can start with the low dose and we can build up the dose. Ivermectin is obtained from the Streptomyces avermitilis. It is again the drug of choice for onchocerciasis and strongyloidiasis and equal to diethyl carbamazine citrate in filaria. Now this ivermectin is often used for the treatment of the filariasis. Also effective in cutaneous larva migrans and ascariasis or like scabies and head lice. So you will see that the scabies infection, head lice infection that leads to different types of the dermatological conditions. It can also be treated with the ivermectin. Ivermectin is an oral drug. It acts by special type of glutamate gated chloride channel found only in invertebrates. That is, only in these worms, this glutamate gated chloride channel are present. They act via this. This is absent in man, but it is also absent in the flukes and tapeworms. That's why for the flukes, that is the trematodes and the tapeworms, we cannot use the ivermectin. Ivermectin is only used for the filariasis, onchocerciasis and strongyloidiasis. Potentiation of the GABA activity, and ultimately the worm muscles are again paralyzed and they are expelled out. They are absorbed well. Half-life is very long for ivermectin, 48 to 60 hours. It is available as 3 to 6 milligram tablet for filaria, single dose 0.2 milligram per kg with 400 milligram albendazole annually for 5 to 6 years. Strongyloides 0.2 milligram per kg single dose. It is replaced diethyl carbamazine citrate in Onchocerca volvulus by WHO. Again, the adverse drug reactions are very less. If you can remember that during COVID time, different drugs are tried to treat the COVID-19. Perhaps some of you have already consumed or your family members have also consumed. This ivermectin has also come upfront during the COVID times, and in some of the guidelines, ivermectin is also given. Can you remember anyone? So this ivermectin is given in COVID-19. In many guidelines it has been given, but ultimately later it has been seen that ivermectin is not effective in case of the COVID-19. But many patients have taken this ivermectin during the COVID-19 times. Another drug is the niclosamide. Niclosamide is highly effective against the cystodes. So different types of the cystodes can be affected by the niclosamide. Cystode means different types of the tinea. So either it is tinea solium or tinea saginata or Diphyllobotrium latum or Hymenopsis nana. Mechanism of action, again, either these two types of the mechanism, all of these acts. So inhibition of the oxidative phosphorylation, so ATP will not be generated, and again there is either flaccid or spastic paralysis, tonic paralysis of the muscles, and the worms are excreted. But the problem of the tinea solium is digestion of the dead segments can be hazardous because the ova which are released from this tinea solium may develop into larvae in the intestine, penetrates its wall, and dangerous visceral cysticercosis can happen. So visceral cysticercosis that may lead to neurocysticercosis also. This can happen with the tinea solium. So that is the problem. So even if we are giving within this cyst, there are different types of the ova of the tinea solium that can spill over in the blood, that can go into the brain also, can develop neurocysticercosis. That can go into the liver or lungs also, and also develop different types of the visceral cysticercosis. When you will read in your helminthiasis class, you will also read about this. So the regimen available as 0.5 gram tablets of niclosamide, 2 gram stat, repeat after 1 hour, and we have to give the saline purgation so that there will be purgation, so that the worms will be excreted afflux with the stool. 2 gram daily for 5 days in Hymenopsis nana infection. Usually the adverse reactions are very less. Praziquantel is another novel anti-emetic. It mainly acts on the schistosomiasis and other trematodes. So niclosamide, remember, they act on the cystodes, and praziquantel acts on the trematodes and cystodes, but not any nematodes. Okay. So they are rapidly taken up by the worms. Again, they causes paralysis. The different types of the paralysis occurs. Similar type, details is not required, and they are also rapidly absorbed. So praziquantel mainly acts against the schistosomiasis and other trematodes, and some cases of the cystodes, but not any nematodes. The same thing, metrifonate. Metrifonate is basically a organophosphorus drug. You have read organophosphorus in your in the anticholinergics. So this is another organophosphorus compound which is used first as an insecticide and later as an anti-helminthic. So it has been seen that they have some anti-helminthic action used especially for treatment of the Schistosoma hematobium. It is a product and ultimately it is converted to an active drug which is a dichlorvos, which is a potent cholinesterase inhibitor, the similar type of organophosphorus. But it mainly acts on the worms and they have very minimal effect on the host cells. That's why it is not toxic to humans. So anti-helminthic treatment of the neurocysticercosis, what I am talking. So this is a dangerous condition that can also lead to death. One of the two anti-helminthic are effective in killing cysticerci. Albendazole is now preferred over praziquantel. Already we have seen the praziquantel is another drug that can be effective against this, but albendazole is of course preferred because the course of treatment is shorter. Only 8 to 15 days is required, while for praziquantel approximately 1 month is required. Cure rates is also more. Resolution of symptoms and disappearance of the cyst will be more. Corticosteroids enhance the absorption of the albendazole but lower the blood levels of the praziquantel. It is often used, corticosteroid is often used for the treatment of the neurocysticercosis. Okay, and albendazole is cheaper. Whichever anti-helminthic is used, this corticosteroid, most commonly prednisolone and dexamethasone is used. That is, must be started 2 days before and continue till 2 weeks after completing the anti-helminthic course, because it is necessary to suppress the anti-inflammatory reactions to the products of the kill larvae. The problem of different types of the cyst killing. So may it be hydatid cyst, may it be cysticercosis, all these cases, if we are doing some surgery or if we are killing the cyst, there are content of the different ova or the toxic materials present within cyst that can spill over to the blood, and that may lead to different types of the inflammatory reactions. That's why we have to start the corticosteroid treatment approximately few days before, and it will be continued till 2 weeks after completing the anti-helminthic course. So this is the standard treatment for the neurocysticercosis. So remember, neurocysticercosis is caused by the Tinea solium. This Tinea solium infestation can go to the different viscera that leads to visceral infections. The most dangerous of this is the neurocysticercosis, and it can be treated by the two drugs. One is the albendazole and another is the praziquantel. Of this, the albendazole is preferred. These are the reasons, that's why the albendazole is preferred, and both corticosteroids and albendazole is required for its treatment. And why the corticosteroid is used before using of the albendazole? Because when we are killing, there will be spillover of the inflammatory contents that leads to widespread septicemia, widespread infection or inflammation that can be tackled by the corticosteroids. So now coming to the drug of choice, albendazole is the drug of choice, remember, of all nematodes except Enterobius vermicularis. For the Enterobius vermicularis, mebendazole is the drug of choice. Vaucheria bancrofti and Bugia malloy. So this causes the filariasis. So usually until now the drug of choice is the diethyl carbamazine citrate. Apart from this, ivermectin is also used. For the onchocerciasis and strongyloides, ivermectin is the drug of choice. And for the Dracunculus medinensis, metronidazole is the drug of choice. We will come to the metronidazole. So for all the nematode infection, nematode means may it be hookworm, may it be roundworm, may it be pinworm. In all these cases, we have to use the albendazole. This is the drug of choice, except few cases like Enterobius, mebendazole. If there is filaria, there is DEC, diethyl carbamazine citrate. If there is Onchocerca strongyloides, ivermectin, and for Dracunculus medinensis, metronidazole. So this is important. Again, for the remembrance, you can see that praziquantel is the drug of choice of all trematodes and cystodes except the Fasciola hepatica. Already we have seen the triclopendazole is another bendazole that is drug of choice for the Fasciola hepatica. Okay, that causes the liver fluke. And albendazole again is the drug of choice for the hydatid cyst, hydatid disease. Hydatid disease is caused by the hydatid cyst. It is caused by the Echinococcus granulosus. Okay. So remember, praziquantel is the drug of choice for all trematodes and cystodes except Fasciola hepatica and hydatid disease. Okay. In this anti-helminthic drug, the most important you have to read about the albendazole. Okay, albendazole, next the praziquantel, treatment of the neurocysticercosis, and the treatment of the filariasis, that is the DEC, ivermectin. So the last part, the anti-amoebic and anti-protozoal drugs. Until now, we have completed the anti-helminthic drugs. Now coming to the anti-amoebic and anti-protozoal. Within the anti-protozoal drugs, already the malaria part has been covered, you know. So now coming to the anti-amoebic drugs. So amoebiasis. Amoebiasis is a problem in our country and many of the countries because of our poor sanitation, because of the environmental conditions, low socioeconomic conditions, etc. And approximately many persons you cannot believe that died due to the amoebiasis. So this is again a very common problem in our country. At least 40,000 deaths are attributable to amoebiasis and rank third among parasitic causes of the death, behind only malaria and schistosomiasis in whole of the world. So this is the trophozoite and the cyst of the amoeba. The most common amoeba that causes the amoebiasis is the Entamoeba histolytica. Again, in the microbiology or parasitology, you will read about this. So this is the structure of the trophozoites and this is the structure of the cyst of the Entamoeba histolytica. So how it causes the pathogenesis? It is a waterborne pathogens. Again, it is transmitted by the fecal-oral route, and due to the poor sanitation, poor environmental conditions, it transmitted from one person to another person. Again, in the school or in the hostels, most commonly it is transmitted from one person to another person. This Entamoeba histolytica exists in two forms. One is the cyst form, another is the trophozoite form. Cyst form is the dormant form which can survive outside the body, and the trophozoite form is a dividing form which is the non-infective and do not persist outside the body, but they invasive. Invasive means they invade the organs and they can co-host with the different types of the organs within our body. So there are two stages of the development. If we are ingesting cyst due to the contaminated water or contaminated food or something like that, it reaches the colon and it transforms to trophozoites from the cyst. Then this cyst can either live as commensals without much problems, but it will transmit the disease to other persons. From cyst that passed on to the stool, again it is transmitted by the fecal-oral route to other persons. And from amoebic ulcers, which causes the acute dysentery, chronic amoebic dysentery, which causes the vague symptoms, and amoeboma, that is again the cyst type formation can occur, and this can also occur in different types of the organs also. So all these three can happen when there is fecal-oral transmission of the ingested cyst. Cyst of the Entamoeba histolytica is ingested within our body. So fecal-oral route, again we can see this is the cyst and this is the trophozoite. So excistation, so cyst by means of the passed in feces, it is resistant and it is infective, and within the body it is converted to trophozoite, and it causes the replication, and more trophozoites are formed. It is mobile and it can invade the organs. So trophozoites can enter the bloodstream and travel to other parts. What I am talking. So they can go to the liver. Sometimes they can be infested to brain or lungs also, and can cause different types of the liver abscess. The most common is the amoebic liver abscess. Very common. Amoebic liver abscess can happen if the amoebiasis is not treated. Okay. So in tissues only trophozoites are present. Remember. So trophozoites is the invading form which is present within our body, but the transmitted form from one person to another person by the fecal-oral route is the different types of the cyst. Okay. So you can see the different organs can be affected. So what are the drugs? The drugs can be divided into tissue amoebicides and luminal amoebicides within the tissue and within the lumen of the gastrointestinal tract. Intestinal and extraintestinal, for example, the most common of this is the nitroimidazoles. Within the nitroimidazoles, the most common drug is the metronidazole. And remember, this metronidazole is not only an antiprotozoal drug, this is also very active against the anaerobic bacteria. So against the anaerobic bacterial infections, the main drug is also the metronidazole, and this metronidazole also acts as an anti-amoebic drug or antiprotozoal drug. So different types of the nidazoles or nitroimidazoles are tinidazole, secnidazole, ornidazole, satranidazole, etc. There are alkaloids like emetine and dihydroemetine, and for the extra intestinal killing of this amoeba, chloroquine is also effective. So this chloroquine is basically an anti-malarial drug that is also effective as an extra-intestinal anti-amoebic drug. Within the luminal amebicide, that cannot kill the amoeba within the tissues, that can kill only within the gastrointestinal lumen. Example is the diloxanide fuorate, nitrous oxanide, quinidochlor dihydroxyquinine, and some antibiotics like tetracycline and paramomycin. So these are the drugs that are effective against the amoeba. So metronidazole, very important. It is a prototype drug. It is discovered for the treatment of the trichomoniasis in 1959. It has shown broad spectrum cidal activity against the different types of the protozoa like Entamoeba histolytica, Trichomonas vaginalis, and Giardia lamblia. And I have already told that it is also the mainstay of the drug for different types of the anaerobic infections. For example, Bacteroides fragilis, Clostridium perfringens, Fusobacterium, Helicobacter pylori that causes the peptic ulcer, Clostridium difficile, Campylobacter jejuni, and different types of the anaerobic streptococci. Apart from this, this is also active against the Dracunculus medinensis or helminths. Already we have seen for the Dracunculus medinensis, the drug of choice is the metronidazole. Till now, no resistance has been shown. So metronidazole active against this. This is important. Mechanism of action. So basically, these anaerobic bacteria of the helminths usually use a respiratory chain. This is a unique to anaerobe. This is known as the pyruvate ferridoxin oxidoreductase pathway or PFOR. Pyruvate ferridoxin oxidoreductase pathway. By this respiratory chain, ATP synthesis happens, and this ATP is required for the bacteria to survive. So metronidazole, firstly, when it is given, it is diffuses within both the aerobic and anaerobic bacteria, but mostly it has bactericidal activity against the anaerobic bacteria and the different types of the protozoa. It is reduced to nitroradicals, and these nitroradicals have some redox potential, and they act as an electron sink. That is, they accept the electron just like that of the agents present in the respiratory chain. So nitroradicals acts as an electron sink. They compete with the biological acceptor sites of the anaerobic organisms for the electrons generated by this pyruvate ferridoxin oxidoreductase pathway for the pyruvate reduction. So when it competes, this metronidazole ultimately accepts the electron. So the respiratory chain is uncouples. The respiratory chain continues, but there will be no ATP production. On the other hand, they also generate different types of the cytotoxic particles, most commonly different nitroradicals, that also interact with the different DNA, and this DNA becomes destabilized and they become destroyed. Cytotoxic intermediate particles interact with this host cell DNA, resulting DNA strand breakage and fatal destabilization of the DNA helix. So both ways. So mechanism of action of the metronidazole is, in the one hand, it destabilizes the DNA and ultimately protein synthesis machinery becomes stopped. On the other hand, it acts as an electron sink, the nitroradicals of the metronidazole. It accepts the electron. It competes with the normal metabolite present within the electron transport chain or respiratory chain. So it decouples it. So the ATP synthesis again hampered. So on the one side, the DNA is destabilized, DNA is destroyed. On the other hand, the ATP is not synthesized. So ultimately, the anaerobic bacteria or the protozoa are destroyed. So this is the mechanism of action of the metronidazole. So again, it is well absorbed from the small intestine, widely distributed in the body secretions like vaginal secretions, semen, saliva, and CSF. That's why if there is vaginitis or prostatitis, in all these cases, metronidazole can be used. Metabolized in liver by oxidation and glucuronidation, and half-life is 8 hours. That's why the dosage of the metronidazole is usually 3 times of the daily. So in many of the cases, you will see that it is given twice daily, but it will not be effective. Most common adverse effects, some metallic taste in the mouth, nausea, vomiting, abdominal cramp can occur, and for prolonged administration, peripheral neuropathy and CNS effects occur, and seizures can happen at high dose. Many of you have already consumed the metronidazole for some diarrhea or dysentery. You know about this metallic taste is already present. So contraindication, first trimester of pregnancy. So metronidazole is widely used in many of these anaerobic infections or different types of the protozoas, but remember, it should not be given in pregnancy. Neurological disease and blood dysphagia can happen, and chronic alcoholism. Because if the metronidazole is given with alcohol, ultimately the aldehyde dehydrogenase enzyme can be affected and disulfiram-like reaction can happen. So that leads to chilling, that leads to dizziness, vomiting, flushing, burning sensation, throbbing, headache, visual disturbance, etc. So usually when metronidazole is given, the patient is asked to abstain from the alcohol at least for the 1 week. So disulfiram irreversibly inhibits the oxidation of acetaldehyde by competing with the NAD for binding sites of the aldehyde dehydrogenase. So this NAD is affected and disulfiram-like reactions happen. So remember, metronidazole and alcohol interactions, disulfiram-like reactions can happen. That's why the patient is asked to abstain from alcohol intake. It is used amoebiasis, first line of the drug. It kills the entamoeba histolytica trophozoites, but it lesser kills the cyst. So trophozoites are mostly killed, cysts are less killed. Treatment of all tissue infections of entamoeba histolytica, mild intestinal, invasive, liver abscess. So all types of the amoebiasis, be it invasive or non-invasive, we have to use the metronidazole. Less effect happens the luminal parasites, so it must be used with a luminal amoebicide. So if it is present only in the intestine, we have to add some luminal amoebicide. Apart from this, giardiasis, Trichomonas vaginalis, it is the drug of choice. Anaerobic bacterial infections, pseudomembranous pleuritis, that is caused by the Clostridium difficile, ulcerative gingivitis, trench mouth, in all these cases, Helicobacter pylori infections that causes peptic ulcer, all these cases metronidazole is used. Apart from this, there are other nitroimidazoles like tinidazole, secnidazole, ornidazole, saturnazole. You will see that now mostly you will have some combinations of the ciprofloxacin or ofloxacin with some tinidazole or ornidazole. Okay, so these are more or less similar. There are some changes in the pharmacokinetics, otherwise these are more or less similar. These are the alkaloids, emetine and dihydroemetine. They are obtained from the cephalids, and the dihydroemetine is a synthetic analogs. They kill the trophozoites of the entamoeba histolytica. They inhibit the intraribosomal translocation of the tRNA amino acid complex. They have actions on the trophozoites, but again not on the cyst. Administered by subcutaneous or intramuscular, oral preparations are absorbed iradically. That's why it is lesser used nowadays. Reserved drug for severe intestinal or extraintestinal amoebiasis for patients not responding to metronidazole. So remember, emetine and dihydroemetine is used mainly systematically because the oral absorption is erratic and it is reserved for resistant amoebiasis infection. Chloroquine, you know, it is an antimalarial drug that also kills the trophozoites of the entamoeba histolytica. Concentrates in liver and used in hepatic amoebiasis. It is used. So for hepatic amoebiasis, chloroquine is used. Completely absorbed from the upper intestine. Efficacy in amoebic liver abscess is equal to emetine, but longer treatment needed and relapse may occur. Used after a course of metronidazole and luminal amoebicide must be added. So when there is infestation of the amoeba within the liver or any of the organ, we have to use all of these agents. We have to start with the metronidazole, which is the mainstay of the drug, and we have to add some other luminal amoebicide and chloroquine. Diloxanide furoate is the most commonly used luminal amoebicide. Diloxanide furoate. It is a highly effective luminal amoebicide. That is the amoeba that is present only within the lumen of the gastrointestinal tract. Kills trophozoites responsible for production of the cyst. However, no antibacterial actions. So nitroimidazoles or imidazoles also have antibacterial actions, but they have only this anti-protozoal actions. So when this diloxanide furoate is given, this is divided into furoate and diloxanide. Furoate is hydrolyzed and it exerts effect, and this diloxanide is freed, 90% is absorbed, and remaining 10% reaches large intestine and also exerts effect. So that is both of this part exert effect in two ways. No systemic antibiotic activity is evident with diloxanide despite its absorption. So diloxanide part is absorbed, but it is used only as luminal amoebicide. If the amoebic infection is present within some organs, within some viscera, it cannot be treated by only luminal amoebicide. Used in mild tissue amoebicide or asymptomatic cyst passers, tissue amoebiasis, liver abscess with metronidazole. Usually it is used in combination with the metronidazole or metronidazole plus chloroquine, etc. It is also well tolerated. Nitazoxanide is another broad spectrum antiparasitic agent. It is mainly used in the giardiasis and diarrhea caused by the cryptosporidia. Mechanism of action is similar to the metronidazole. Hydroxyquinolines. Previously, it was very commonly used for the diarrhea or dysentery. So the drugs are the iodoquinol, siloquinol, quinodochlor, and iodochlorohydroxyquine. So they are active against the entamoeba, giardia, trichomonas, and against some fungi and bacteria also. They have again some luminal amibicidal action, but no tissue action. They are not effective in acute dysentery, but in chronic intestinal amoebiasis. So when there is chronic intestinal amoebiasis, we can use the 8-hydroxyquinolines derivative. They are absorbed very less amount, and previously these are the very common drugs, but it has been seen that if it is given for the long period of the time, a typical adverse effect known as the subacute myelooptic neuropathy can develop. Suboptic myelooptic neuropathy. This is an inflammation of the optic nerve causing a complete or partial loss of vision and also peripheral neuropathy occurred by prolonged or repeated dose of the relatively high doses of the quinodochlor, and it was seen mainly in the Japan. These are used alternative to diloxanide in amoebiasis, giardia, local treatment of the vaginal trichomonas, fungal, and the bacterial infections. You have probably heard of the brand name, the enteroquinol. Previously, enteroquinol or these types of the 8-hydroxyquinolines were indiscriminately used, but with the advent of the newer drugs, it is very less used, and even if it is used, it should be given for the minimum amount of the time, because if it is given for the larger amount of the time for the large doses, that leads to suboptic myelooptic neuropathy. This is important. Why it is less used? Tetracyclines is an antibiotic. This is also used. Mainly it is used for the entamoeba infections because they have inhibitory action on the entamoeba. Details is not required. Choices of the drug, the same thing, the different types of the imidazoles. Now coming to the trichomonas vaginitis infections, metronidazole or tinidazole is usually given, and in all of these cases, it should be repeated after 1.5 months. Additional intravaginal treatment for refractory cases is given. Both partners should be treated, and local application of the quinodochlor, clotrimazole, natamycin, povidone, etc. given. So trichomonas vaginitis is sexually transmitted, so both partners should be treated. Now, another important thing is the drugs for the leishmaniasis. So, Kala-jar. Kala-jar is very frequent in our country, in Brazil, and in some of the East Africa.